Hi everybody, welcome to Basic EKG Interpretation. Sorry, I started on the wrong screen. This is the narration that's supposed to go along with the Basic EKG Interpretation packet. Hopefully you've had the opportunity to print the packet and have it in front of you, and that way you can take notes. The way the packet is printed out, it'll be a little bit easier to look at the strips and take notes and figure out what's going on. And so that's why I want you to do that. Sorry, I hate to make you print things. But anyways, get yourself all ready and let's get going. First off, we want to look at the objectives. What are we going to try to do? What should you come out of this with? We want to describe the normal sequence of electrical conduction in the heart. We're going to be looking at EKG complexes, and within those complexes, we're going to identify a normal P wave, a QRS, and a T wave, and know what that means. We're going to be looking at specific strips, and you're going to need to be able to know these for testing. The following: sinus rhythm, sinus bradycardia, sinus tachycardia, atrial fibrillation, supraventricular tachycardia, VTach, VFib, asystole, and third-degree heart block. Now, I did put some extra things in here. We have first and second degree heart block is an extra. Now, ACLS, when you take the ACLS test, it will test you on second and third degree blocks. And paced rhythms I'm putting in as information. We'll be talking about pacemakers. They can look a little bit weird. So other than first and second degree heart blocks and paced rhythms, you need to know all of the other ones for testing. So highlight them or whatever you need to do. Now, the other piece of it that's very important is we're going to be discussing the hemodynamic effects and management of selected rhythms, because it's not enough to look up at the monitor and say, oh, gee, I have a patient that's in supraventricular tachycardia. I've got to know what I'm going to do after that. And so we'll be going over that too. I want to do a cardiovascular review first. We're talking about the conduction system, but still you got to have a little bit of a review of the heart, and this is going to help you just in the cardiac section in general. Remember that when we're looking at the heart, we have atria and ventricles. Atria are really there only as reservoirs for the ventricles. Atria hold blood that's collecting as the ventricles are contracting. And so these are very low pressure chambers, not terribly hard working, and we can survive just fine without functioning atria. If you look at a patient that's in atrial fibrillation, the atria really never contract, they just quiver, but we manage to get cardiac output. I'll explain that all to you. Ventricles, though, we need. So ventricles, we know we have right and left side. And we often talk about the heart as right and left sided. The right side of the heart basically doesn't have to pump against very high pressure, so it's kind of not a big hard-working side of the heart. Hard-working side of the heart is the left side of the heart because it's got to push out blood to the body. So the right ventricle is a very low-pressure chamber, and it, of course, has the deoxygenated blood that is going to pump to the pulmonary artery, and that's going to get, go through the alveoli and become oxygenated. From the left side of the heart, that has to be a high-pressure, hard-working chamber. The left ventricle has to work really hard because it's got to create enough forward force to move blood past the aortic valve to the body. So it's got to generate higher pressure than what is on the other side of the aortic valve. And so, of course, the left ventricle is pumping oxygenated blood to the body, and it's really the largest muscle mass of the heart. Other structures within the heart include the valves. Now, the purpose of valves are to keep blood moving in a forward direction. So we have our atrioventricular valves, and those are in the atria. Atrioventricular makes sense. Tricuspid is on the right side of the heart, and mitral is on the left. They're kind of funky, billowy little valves that are attached to structures called chordae tendineae, and then those chordae tendineae are anchored to the inside of the ventricle. Now, remember that valves in general keep blood moving in a forward direction. And when we're listening to the heart and we hear lub-dub, the lub, or S1, is created by closure of the AV valves. Semilunar valves are your pulmonic on the right side and aortic on the left. Same thing, they're there to keep blood moving in a forward direction. And when we're listening to lub-dub, dub is closure of those semilunar sounds. So lub and dub are just valves closing. Other structure are very important are the coronary arteries. The coronary arteries are supplying blood to both the mechanical, meaning the myocardium, the muscle, and the electrical, we're going to be talking about the electrical pathways of the heart, the specialized cells that do that. The coronary arteries are supplying oxygenated blood to those structures, and so that's a very important thing. It's important to note that about 75 to 90% of coronary artery filling and perfusion of the heart occurs during diastole, and that makes sense. During systole, we have a lot of pressure, and blood has to flow from a high to a low pressure, and so we need lower pressure during diastole to allow blood flow through the coronary arteries so that we can perfuse the myocardium. You want to have an understanding of how blood flows through the heart. When you're thinking about heart, and a lot of people get kind of freaked out about the heart, it seems very complex. And it's really a very simple system. It's a plumbing system. It's plumbing and it's electric, and electric's kind of scary. But anyways, plumbing's not. I mean, think about this. If you're at home and you stuff a bunch of toilet paper in the toilet and you flush it and you think it's going to go through, it's not. It's going to clog and water is going to flow back up over the top of the toilet. So it's kind of the same thing. We've got to move blood forward we have to move blood in a forward direction. So add blood flow through the heart. If you kind of get this is going to help you figure out some of the conditions that occur with the heart. So if I'm a deoxygenated red blood cell coming up through the inferior vena cava, first chamber in the heart I'm going to hit is the right atria. From the right atria, we're going to pass through the tricuspid valve into the right ventricle. From the right ventricle, we're going to pass through the pulmonic valve into the pulmonary artery. Pulmonary artery is going to take us to the alveolar surface area for gas exchange. Then the oxygenated blood is going to collect in the pulmonary veins, and then hit the left side of the heart in the left atria, pass the mitral valve into the left ventricle, and then pass the aortic valve to the body, our oxygenated blood. So why is this going to help you in class? Well, think about it this way. If something happens to the left ventricle and it doesn't pump very well and it doesn't move all of the blood forward, we have extra blood initially in the ventricle, but then that's going to back up to the left atria. That's going to back up into the pulmonary veins. That's going to create higher pressure. That's going to cause fluid to move out of the vessels into the tissue. That pressure continues to build, fluid's going to move into the alveoli, and you're going to have crackles and fluid in the lungs. If something happens to the right ventricle and it doesn't move volume forward like it should, then once again we're going to have extra volume in the ventricle, and that's going to give rise to more volume and pressure in the atria, and that'll give us more volume and pressure in the vena cava, and we're going to see jugular venous distension because of that. So just keep all that in mind as you're thinking about certain, the cardiovascular conditions. It's plumbing, but it's also electricity. And so that's what this is all about. Now, when you look at the heart, if you slabbed a heart open, you wouldn't see these stripes and everything through the heart. You would just see what looks like, a bloody mess of tissue. So we won't be doing that. But anyways, when we look at the heart, we've got cells that are specialized as pacemaker cells and cells that are specialized as contractile cells. And so what you see that's yellow that looks like tract are the specialized pacemaker cells. Why are pacemaker cells specialized? Those cells, particularly the SA node, have the ability to get ready to initiate an electrical impulse faster than any of the other cells in the heart. And so there's a cluster of cells in the SA node. It's the SA node, sinoatrial node, it's considered the pacemaker of the heart. And by the way, if you're looking at the handout packet, the next page has all of kind of the notes, so you can peer at the picture and look at the next page that's labeled the conduction system of the heart too, because it'll keep you from having to write too much. So the SA node is up there in the right atria near the superior vena cava. Captain of the ship, as I said, the main pacemaker. It'll fire off an impulse typically around 60 to 100 beats a minute. Now the SA node is influenced by the sympathetic and parasympathetic nervous system. So if we've got a lot of sympathetic nervous system stimulation, we'll have a faster heart rate and more contractility of the heart. If parasympathetic is what's predominant, then we'll have a slower heart rate and less contraction of the heart, less contractile ability. So from the SA node, that electrical energy is going to move through cells of the atria, and that atrial, that wave, it'll be kind of a wave of electricity that'll move through the cells of the atria, and as the electricity is moving through those cells, it causes what's called depolarization. Depolarization is actually movement of ions, and so what happens with depolarization is that sodium moves into cells and potassium moves out of cells, and that depolarization should stimulate contraction. So you've got the electrical energy, depolarization, which is movement of ions, and then contraction. Now we'll get our contraction of our atria. The energy, the electrical stimulus, stops at a structure called the AV node. And the reason it stops there is that the heart, the atria and the ventricles are actually divided by a fibrous plate that valves sit on. And so that's why impulses can't jump typically directly from the atria right to the ventricles. That's why there's this little stop in the AV node. And that's a good thing, because that stop and the AV node are protective of the ventricles. So the AV node does a couple things. One is that there's a tiny little delay at the AV node. It's just a very little fraction of a second, but that's important because that little delay allows better filling of the ventricles, and that's good. The other thing the AV node does is that it'll protect the ventricle from really high atrial rates. So example, probably the best one, is atrial fibrillation. When we talk about AFib, it's like a chaotic electrical storm going on in the atria. We can't count how many electrical impulses hit the AV node, but it may be 400 or more a minute. Now, that means the atria is quivering, and we can live with a quivering atria, but we can't live with a quivering ventricle. That's called VFib, and that's dead. So the AV node is going to protect us by only allowing some of those impulses through. It's not going to fire all 400 or 500 a minute through. So that's a good thing. It's a gatekeeper. One last thing that is protective is that the AV nodal tissue has kind of a fail-safe in that if something happens to the SA node and it's not functioning, there is some tissue around the AV node that is kind of the second pacemaker of the heart. And so if there's no signal from the SA node, the AV nodal or junctional tissue will begin to fire and stimulate the ventricles. And that rate is a little slower. It's intrinsically somewhere between 40 to 60 beats a minute, but it's also stimulated by the sympathetic and parasympathetic nervous system. So from the AV node then, the impulse continues to travel down through what's called the bundle of His, and then you'll notice we break off into these bundle branches. And so we've got a right bundle branch, and then we've got two left bundle branches. Now remember, as the electricity is traveling through, it's causing a wave of depolarization through the ventricle that's going to cause ventricular contraction. Now these Purkinje fibers that look like tree fibers, this is the terminal portion of the conduction system, and this is actually the very last fail-safe that we have. If something happens and both our SA and AV nodes are taken out, heart attacks that affect certain areas of the heart can do this, then the Purkinje fibers, or there's some specialized cells in the bundle of His, can also take over and pace the heart. Very slow, is typically about 20 to 40 beats a minute, but it'll keep you alive until we can get a pacemaker or something in. So our last fail-safe. As I said, now remember that this electrical stimulation is going to cause depolarization. If everything's going well, contraction will follow that. Physiologic properties of cardiac cells. So this is really should probably be entitled Physiologic Properties of Pacemaker Cells. So pacemaker cells have automaticity, excitability, conductivity, and contractility. Cardiac cells have properties too, but it's primarily our pacemaker cells. So automaticity is the ability of those pacemaker cells to initiate an electrical impulse, and we're happy that pacemaker cells are doing that instead of all cardiac cells, because you can't have every single cardiac cell trying to initiate an impulse. It just isn't going to work. Excitability is how well they respond to an electrical stimulus. We need a response, but sometimes the heart gets a little too excitable, and we've got to look at antidysrhythmics to kind of calm things down a little bit. Conductivity is the ability of the cardiac cell to take that stimulus and conduct it to an adjacent cell. And then contractility is the muscle cells, and it's the ability of those muscle cells to shorten, causing that muscle contraction that is a response to the electrical stimulus. Now, the reason I had mentioned before that these should sound familiar to you, these terms, is because when we're giving cardiac medications, we're mucking with these things. As I mentioned before, if we've got dysrhythmias because the cells are too excitable, then we're going to look at antidysrhythmics. If we have some issues with contractility and maybe we don't have adequate contractility, then we can look at medications to improve that. And so some examples would be things like dopamine or dobutamine or even digoxin to improve that. If we need to decrease contractility, and sometimes we have to do that to reduce workload, then we look at medications like beta blockers. Beta blockers will not only reduce contractility, but it'll reduce the heart rate a little bit too. So we're adjusting medications to target these things and make the most of getting a good cardiac output and trying to preserve the heart muscle if need be. Before we look at EKG, once again, make sure that you understand that EKG is just a graphic recording of electrical activity generated by the heart. You can have what looks like a beautiful sinus rhythm on the monitor and be dead. What do I mean by that? It's just electricity. That doesn't mean it's actually capturing and causing any changes to the myocardium. And so, we like EKGs. They're a good piece of diagnostic. It's information. And it can tell us some things. It can show us primary conduction abnormalities. So examples of that would be like heart blocks and things like that. It can show us dysrhythmias, cardiac hypertrophy, pericarditis, electrolyte issues. You guys probably all learned, patients who have hyperkalemia will have flattened P wave and tall 10TT waves, and heart attack. If we have a patient where we suspect a heart attack, one of the first things we want to do is get a 12-lead EKG. That 12-lead can tell us where, if there is a STEMI, and it can tell us what part of the heart is affected. So there's a lot of good uses for this, but like I say, this is just a piece of things. You always want to use that in conjunction with your assessment of the patient. We want to make sure that, they still have a pulse and they're breathing and all that other stuff. So you want to make sure that you treat the patient and not the rhythm. The other thing to keep in mind, a little food for thought here, is that we do have to have electrical activity in order to stimulate. So it has to precede the mechanical activity. We're not going to get anywhere unless there's electrical stimulus. But the most important thing to remember is that electrical activity can occur without being followed by mechanical activity. So that's what I said earlier. You can have what looks like a lovely rhythm but not have a beating heart. Or you could have a beating heart, but it's just not pumping adequately to give us any cardiac output. You must assess the patient. When we're looking at EKGs, you're going to notice that it's printed on this weird graph paper. And so the printout can be a strip that pops out of the monitor defibrillator, or it can be printed on an 8.5 by 11 inch sheet of paper where we have up to 13 seconds or so of strip at a time. Now, regardless of how it's printed, when you look at the paper, you notice there's a series of boxes. And so when you look at the boxes in the vertical axis, the up and down, that represents voltage. Now, voltage is something we can look at in a 12-lead EKG. So you'll notice 5 millimeters, and so it shows you one of these bigger boxes represents 5 millivolts. Now, for what we're going to do with our little strips and we're looking at a lead at a time, voltage isn't going to be anything that we can really look at. It's not going to be important. Our focus is going to be on the horizontal axis across here. The horizontal axis reflects time. So how does that work? When we look at these little boxes, and the teeny tiniest boxes that are here, I wish I had my arrow and not this little clicky thing, but the teeniest, tiniest little boxes that are here, I call, let me get rid of that, I call baby boxes. It went away again. So this little itty bitty teensy tiny thing here is the baby box. And you'll notice that there's 5 by 5, so 25 baby boxes in this bigger outlined bigger box. And so that's what's shown here. It's blown up here. So this is my baby box, and it's a little 1 millimeter box, 1 millimeter square. From here to here, when we're looking horizontally, that little baby box is 0.04 seconds. So here to here, 0.04 seconds. Or when I get down here, here to here, 0.04 seconds. That's not a lot of time. So we're trying to look at time here. So in order to make it a little bit easier, we have 5 of those baby boxes across. 5 baby boxes across, here to here, represents 0.20 seconds. So how does that work? So from here to here is 0.04, and then I go 0.08, 0.12, 0.16, 0.20. So here to here is 0.20 seconds. Here to here, 0.20 seconds. Okay? So we're going to get even bigger with that, but horizontal axis. When we're looking at a strip in general, in order to make it a little easier for us, we've got our baby boxes, we've got our bigger boxes, and then a lot of times at the top or bottom of the strip, you're going to see these kind of slash marks there. So the slash marks are going to help us with time. From here to here is 3 seconds, so it'll give us a 3-second interval. How does that work? Let's go back to this. Remember, baby boxes. This teeny tiny little baby box here to here is 0.04 seconds. If I go from here to here, that's 5 baby boxes, and so that's 0.20. So let's do it again. 0.04, 0.08, 0.12, 0.16, 0.20. Okay, so 0.2. Add another 0.2 is 0.4, 0.6, 0.8, 1 second. 0.2, 0.4, 0.6, 0.8, 2 seconds. 0.2, 0.4, 0.6, 0.8, 3 seconds. Okay, so here to here is 3 seconds. And I got another grid over here. One way to do a quick estimate of heart rate that I'm going to be showing you is to find 6 seconds worth of strip and count complexes within that 6 seconds and multiply times 10 to get a little bit of an estimate. So we're going to be doing that. So here's a strip, and there's not a heart rate on it, and I need to figure out what the heart rate is, and I just want to do a quick estimate. Now, if you look in your Lewis book, the Lewis book does outline a couple different ways to calculate heart rate. This will work, this method will work whether the rhythm is regular or irregular, but it's only an estimate. It can be off by about 5 beats per minute either way. So, what did I do? It says I need to find 6 seconds worth of strip first, and so this one has a lot of marks. So here to here is 1 second, 2 seconds, 3 seconds. So my here to here is 3 seconds. Here's my next big grid. So this is my full strip here is 6 seconds. So I'm going to count complexes. You can either count the P waves, which are these little bumps, or you can count the QRSs, and they're easier to see. So I'm going to count them, and I'm going to count the complete QRSs within 6 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 complexes in 6 seconds. I need to know what it is in 60 seconds, so I'm going to multiply times 10, and that gives me 90. So I'm estimating this strip that this is a rate of about 90 beats a minute. Remember, it's just an estimate, but it'll give me a good ballpark. Why do I care about that? Because when you look at the monitor, it's going to display rate. When you look at a printout of a strip, it's also going to display a rate. But the monitor can't always account for patient movement, for leads that aren't sticking the way they should. Sometimes there'll be artifact. Example, if a patient is shivering or if they're having a seizure, then the muscle movement is going to look like an EKG complex to the monitor strip, and it'll count it. And so all of a sudden you've got alarms going off, and it's saying, yikes, it's 180 beats a minute, but you see a bunch of squiggly stuff all over the place, and you look through the squiggly stuff and you realize, wait a minute, that's not the actual heart rate. So we do use that in clinical practice, and I'm trying to get you guys, I want you guys to get used to the time aspect of things. So on most of the strips, I cut the time off because I'm going to make you figure it out. Terminology, we've been talking about these just to make sure that you guys understand what this all means. Depolarization was the first thing we talked about. Remember, we get our electrical impulse, and that causes depolarization, and that's sodium moving into cell and potassium moving out. Depolarization then will cause the contraction of the myocardium. Now, if we depolarize and we move these ions around, we got to put them back, and that's what's called repolarization. So that's putting things back to where they belong. Now, this is passive, but this requires energy. And so the sodium-potassium pump needs glucose and oxygen in order to function. It's got to actively transport the sodium out of the cells and pull the potassium back into the cells. This is where, for example, patients that have a heart attack, it'll cause, the infarction causes ischemic conditions, and we have less oxygen available, and oxygen and a lot of times glucose for the sodium-potassium pump, and it'll affect repolarization, and we'll see dysrhythmia because of that. So we want to monitor that. Baseline. When things are happening, so we'll be talking about this, when the SA node fires off, it creates a little waveform. As energy is moving through the ventricle, it creates a waveform. When there's no electrical energy or movement going on through the heart, the EKG will have a resting point, a starting line, a flat line. That's what's called isoelectric, and I'll be showing that to you in just a second. And then wave just means it's a baseline from that isoelectric, or a deflection from that baseline. And that deflection can be either upright or positive or negative, and it really depends on whether the energy is moving towards or away from a positive electrode. The EKG complex, a normal EKG complex, we're going to see three separate sorts of waveforms. The first one we're going to see is what's termed the P wave, and we see this nice little, it's green, so you can say a nice little bump of a P wave. The second waveform we typically see is the QRS, and that is our Q wave that goes down here, and then our R wave up here, and then our S wave. And so together, this is the QRS, and then we have the T wave. Okay, so what do these all mean? So the P wave, back over here again, P wave is that first upward deflection, and it should look like this. It should be upward and kind of roundy. It shouldn't be biphasic. It shouldn't be upside down. But the P wave, it represents atrial depolarization. And so what happens is, and first off I want to point out something. Do you see how the line right here is flat and then we get our bump? But then we go back to flat, we get another bump, and then we go back to flat. This is that baseline that I was telling you about. This is the isoelectric line. Nothing electrically is going on here, 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 and here. And so I can take and draw an imaginary line, and everything, when there's not a waveform, everything should be back on that imaginary line. That's what's called isoelectric. Back to the P wave. So this is atrial depolarization, meaning at this point, the SA node fired off, and then what we're seeing is that energy moving, that depolarization wave through the atria that creates this bump. And remember, that's going to be sodium moving into cells, potassium moving out. Contraction will follow that. Then we have a little pause because there's nothing going on electrically. Remember, there's a little pause in the AV node, so the AV node gives a little bit more time for the ventricles to fill. So we've identified the P wave, and that's our atrial depolarization. We have the little pause. We're going to do some measurements. Now, you're going to see 3 measurements that we're going to do typically. And those measurements are all across the horizontal axis because we're trying to figure out how long it takes impulses to move through the heart. We're going to compare with normal and see if the impulse is able to move through the heart as fast as it should. So the first measurement we want to make is what's called the PR interval. And so the PR interval is going to be from the beginning of the P wave. So I've got to be looking at my strip, and I see that I have my baseline, and then do you see right at this point where that waveform starts to lift off of baseline? So that's going to be the beginning of my PR interval, and so I've got that right here. That's the beginning of my PR interval. Now I'm going to follow, here's my P wave, and here's that little resting isoelectric point. And the PR interval gets measured from the beginning of that P wave to the beginning of the QRS. And so I see here's my little isoelectric point, and then notice now that the waveform changes and it moves off a baseline. So this point right here is where my QRS begins. This is my end measurement for PR interval. So PR interval goes from here to here. Now, normal PR interval is between 0.12 to 0.20 seconds. Remember, each of the tiny baby boxes was 0.04 seconds. And so, in terms of baby boxes, 0.12 seconds would be 3 baby boxes. 0.20 seconds would be 5 baby boxes. So you should have 3, 4, or 5 baby boxes as your PR interval. And I'll show you how to do that when we're actually looking at strips, okay? What happens if it's too short? What happens if I measure the PR interval and it's 0.10, so it's only 2.5 baby boxes? Well, that tells me the impulse did not come from the SA node. It came from something a little bit closer to that AV nodal area. And so that means that that junctional tissue probably is what had to fire off. And so it's probably a junctional rhythm. If I measure the PR interval and it's too long, if it's greater than 0.20 seconds, then that means that the AV node hung on to the impulse longer than it should. Remember, it's going to hang on to the impulse for a teeny tiny fraction of a second, but if it hangs on too long, then we may be looking at a first-degree AV block. Okay? All right, so I've got my P wave, my PR interval. I'm going to look at the next complex, and that's my QRS complex. Now, we may not see all of these waveforms, but the Q wave is the first downward waveform. And so I've got a teeny tiny little Q wave here. A teeny tiny little Q wave is fine. In certain leads, a big Q wave is not fine because it can indicate a heart attack. But this little itty bitty Q wave is okay. So here's my Q wave, and then this upward stroke is the R wave, and then the downward stroke that follows that R wave is my S wave, okay? So Q wave, R wave, S wave, and so together this is my QRS. So the QRS represents ventricular depolarization, and it's big because the ventricle, especially the left ventricle, is a big muscle. And so that's why it looks so ginormous because of that. Now, we look at the QRS complex, and we're going to look through the strip, and we're going to make sure that that we have a QRS complex all the way through, and that all of the QRS complexes we see look the same. And then we're going to do another measurement. And so the measurement is going to be from the beginning of the QRS complex to the end, because we want to see how long it took that wave of energy to travel through the ventricles. And so you've got to find the point. Remember, this flat line is my isoelectric line. Nothing's going on electrically. You have to find the point where the QRS actually starts. And so it starts right here, and then you watch until it goes back to baseline. This is the end of the QRS right here. And so my measurement is actually going to be from here is where I'm going to start to here. and it's fairly small, 0.06 to up to 0.11 seconds. Now, 3 baby boxes would be 0.12 seconds, and so if we go all the way to 3 baby boxes, that's a little too long. 0.06 is going to be a baby box and a half. So the impulse actually moves rather fast through the ventricles. So normal 0.06 to 0.11 second. What happens if it's too long? Well, if we do our QRS measurement and it's 0.12 or 0.14 or 0.16, then something slowed that energy down as it moved through the heart. And so it may be scar tissue, it may be hypertrophy, something's going on that slowed things down. If it's less than, sometimes I'll see a QRS that's 0.04 seconds. That's not a worry. It's perfectly fine. Okay, from there, the next thing I'm going to look at is what's called the ST segment. Now, the ST segment isn't a waveform. The ST segment is the period of time between ventricular depolarization and ventricular repolarization. The next waveform we see, the T wave, is ventricular repolarization. But between those two things, nothing should be going on electrically. And so because of that, the ST segment should be a flat, straight line that is at baseline, or isoelectric. So remember, my isoelectric line is right along here. The ST segment should also be at baseline. When it's at baseline, I would call it isoelectric. Now, what if my ST segment was up here? Then I have an elevated ST segment. And although it can be other things, think heart attack, so STEMI. And so, you know, we need to do some more assessment of the patient. If I look at my ST segment and it's down here, okay, so my QRS would come down here, my ST segment would be down here, then my T wave would come up after that. That's ST segment depression, and that has many reasons, but it could be ischemia of the heart, or it could be an electrolyte imbalance, so you'd want to check out the electrolytes. Excuse me. All right, so ST segment isn't something you measure. You're just going to look at it in relationship to the isoelectric line. Is it isoelectric, elevated, or depressed? Then the last waveform we should see is what's called the T wave. A T wave should be like this. It should be upright and rounded. It shouldn't be flat. It shouldn't be tall and tenty, and it shouldn't be upside down or inverted. So we want to see a nice upright and rounded T wave. What does the T wave represent? Ventricular repolarization. And that's, remember, this was depolarization. This is repolarization, where we have to have the sodium-potassium pumps, you know, pushing sodium out of the cell and putting potassium back in. So it requires energy. And so that's why it's important to look at this and make sure it looks the way it should. So we look at it, and then we're going to do a measurement. And so the measurement is called the QT interval. And so that measurement, QT, is going to be from the beginning of our QRS, and this one actually has a Q wave. So the beginning of the QRS is right here to the end of the T wave. And so from here to here, and that's what's lined up here, here to here. And so that measurement should not be any longer than 0.44 seconds. And so that's 2 baby boxes plus, or 2 big boxes plus a baby box. Why do we care? We don't really worry about the QT interval if it's shorter than 0.36. Heart rate will make a difference in QT interval. So here's the thing with QT interval. It is influenced by heart rate. It's influenced by patient sex and patient age. When do we care about the QT interval? When it's too long. Now this 0.36 to 0.44, this is okay in somebody who's got a heart rate of 60 to 70 or 80 beats a minute. But when the heart rate is too slow and too fast, then this has to be adjusted. And that's more than we need to talk about with this kind of strip. So why is it an important consideration? When we look at, so this wave was depolarization, and then nothing's going on, and then at this point we've started to repolarize, shift things around. If the ventricle is cranky, and that cranky ventricle has an area that managed to fire off an impulse, if the impulse hits during this part of the cardiac cycle, it won't do anything. It won't cause the heart to respond in any way. but from the peak of the T wave to this baseline here at the end of the T wave, this part right here is called the relative refractory period. This is a sensitive time in the T wave. And if I had a ventricular ectopy, and it's typically a PVC, that lands on the back of the T wave, my heart can respond, but it's typically not normally. The response can be lethal dysrhythmia, such as VTAC, VFib, or torsades de pointe. And so the longer my QT interval is, the longer that danger zone is too. And so that's why I get concerned about the QT interval. I want to make sure that it's not too long, that it risks the patient developing a lethal dysrhythmia. Now, what could prolong QT interval? It can be a genetic finding. It can also be medications. There are many antidysrhythmics and, scarily, some over-the-counter medications that can prolong the QT interval. We'll talk more about that in class, but we want to do that last QT interval as a measurement. So if you're going to analyze an EKG, when you get some practice with EKGs, you get to the point where you can look at them and you know, oh, okay, that's a sinus rhythm, or that's atrial fibrillation, or that's VTAC, or whatever it is. And so, you do some measurements and things like that. But sometimes, even the most experienced of us, people will do wacky things on the monitor and you're not sure what's going on. And especially when you're just learning this, you need a roadway, you need a path. And so that's what this is about. You need an algorithm. And so we need to look at this in a step-by-step manner and figure out what's going on with the patient. So step 1 and step 2 are interchangeable. We're going to use this algorithm to go through strips. Step 1 is rhythm. We're going to determine whether the rhythm is regular or irregular. And I'm going to show you how to do that. Basically, we're going to look at either P to P interval or R to R interval, and we're going to march it out and make sure that there's a consistent interval through the whole strip. If it's not consistent and it's irregular, then we want to figure out, is it irregular all the way around with no pattern, or is there a pattern to it, such as an early beat or a late beat? The next thing we want to do is figure out what the rate is. And so does it fall within the normal range of 60 to 100 beats a minute, or is it too slow, less than 60 beats a minute, or too fast, less than or greater than 100? And, we always have to look at that rate with other findings. What would be going on with the patient? Is there a reason? Is this compensatory? Is there something we need to fix or whatever if the rate is out of whack? The next step is going to be to look for P waves. So remember, that's that first bump, that represents atrial depolarization. And so that's going to tell us whether the atria fired off and all of that. So we want to see P waves. We should. And once you've identified P waves, you need to look to make sure that there's a P wave before every QRS and that the P waves all look the same throughout. If the shape changes, if the PR interval changes, then that's not a good thing. And if there's not a P wave in front of every QRS, then we're not looking at a sinus rhythm. So we got to figure out what the problem is. We've identified P waves. Now we want to figure out the PR interval. And remember, it should be somewhere between, normal is between 0.12 and 0.20 seconds. So that was 3 to 5 baby boxes. If it's too short, it's likely a junctional rhythm. If it's too long, it's likely a first-degree AV block. And the other thing that's important is that PR interval should be consistent all the way through. You shouldn't have a PR interval 0.16 on one complex and then 0.22 on another. They should be consistent throughout. All right, next thing we're going to do is identify the QRS complex. Well, you do need to have that because remember, that's ventricular depolarization. If all you got is P waves, then your patient's dead, so we need to see QRS complexes. And the QRS complexes should look the same all the way through the strip. If they change in shape or configuration, then the impulse isn't moving through the heart the same way each time, and that would need a 12-lead EKG to figure out why. We're going to measure our QRS from the beginning to the end of the QRS, and it should be less than 0.112 seconds, so up to 0.11 second. After we've examined the QRS and measured the QRS interval, we're going to look at the ST segment. Remember, that should be isoelectric. It's a period of time between the QRS and the T wave when nothing should be going on electrically. So it should be a straight line that is at baseline, and that means it's isoelectric. We're going to find our T wave. That should be our last waveform. It should be upright and rounded. It shouldn't be tall and tenty. It shouldn't be inverted. And we're going to do a last measurement, that's the QT interval. And remember, that measurement will start from the beginning of the QRS to the end of the T wave. And that should be for most, as long as the rhythm's somewhere between 60 to 80 beats a minute, it should be less than 0.44 seconds. And so that's how we're going to be analyzing EKGs. That's the end of the first section. So go ahead and close this out, and then we'll be moving into atrial, normal rhythms and atrial dysrhythmias. So thanks for now.